going to call up our next speaker. He's coming from the back. He has a long walk, but this is this is Dr. Stephen Harward. He's one of our neurosurgeons here at Duke. He's at least a triple D Dookie. Did you do undergrad at Duke too? He's a quadruple D Dookie. And he's going to be speaking on neurostimulation.
Awesome. Thank you so much.
You got the Rolling Stones.
All right. Yeah, so I'm one of the neurosurgeons here, and kind of my specialty is doing deep brain stimulation. We don't do a lot of it for blepharospasm. We'll talk a little bit about that. But my big goal is just kind of introduce this therapy, because you'll see this is a therapy that we're starting to use more and more in neurosurgery for circuit-based conditions. So what is deep brain stimulation, for those that aren't familiar? So this is a therapy that's been available for about 30 years or so. It's a neurosurgical procedure where we actually place electrodes into the brain. And we connect those to a battery that sits in the chest, very similar to a pacemaker. And through those electrodes, we give high-frequency continuous stimulation to very specific areas in the brain. So you can see in the images here, we've got a couple areas highlighted. The globus pallidus, which is the one that's going to actually be relevant for blepharospasm, as well as subthalamic nucleus, areas of the thalamus, other areas, etc., depending on the disease that's being treated. And the goal of this therapy is to try and disrupt pathologic circuit activity, to basically prevent whatever is driving the symptoms for the condition that you're trying to treat. I said it's been around since the 1980s, and it's been performed for various indications almost over 200,000 times, so a lot of experience utilizing this. So how is it used? The two main indications, Parkinson's disease and essential tremor, these are both FDA approved and been using them since the late 1990s. But then dystonia is a newer indication in the last decade. There is a humanitarian device exemption, and a lot of the work that's been done for blepharospasm has kind of fallen under this category, if you will. Also, there's new indications for obsessive compulsive disorder as well as focal epilepsy. And in fact, we're using it for at least 3 of these indications here at Duke, namely Parkinson's, tremor, and focal epilepsy, and hope to be, Parkinson's, tremor, dystonia, and also focal epilepsy, and hope to be getting into obsessive compulsive disorder in the near future. Other indications, so the future of DBS. So the people are looking at many, many other ways of utilizing this therapy to target a wide variety of brain diseases. So as you can see here, the list is quite extensive, ranging from depression all the way down to addiction. And blepharospasm is one of those that has started to begin, people are investigating as a possible tool. I'll point out that because this is a stimulatory therapy, it's trying to disrupt circuit activity. It is common, this is not a cure for any of these conditions, but it's a way to try and make the symptoms more manageable, induce some of the plasticity that we heard about in some of the previous talks, as a way to try to undo some of the pathologic changes in these circuits. So why even consider DBS for a condition like blepharospasm? Why people thought this would be a good thing to consider? So I think the previous talk did a very nice job talking about some of the circuitry that's involved with blepharospasm. Well, like I said, DBS is a tool that we use to disrupt that pathologic circuit activity. And specifically, it's been shown to be very effective in some types of dystonia, where we're targeting an area of the brain called the globus pallidus, putting the electrodes there, stimulating that. That has been very, very helpful. And blepharospasm is kind of a subtype of dystonia, because once again, instead of being contractions of the neck, trunk, arms, and legs, it's once again involving the blink reflex, etc. And so there's been a lot of data out there showing that DBS works for dystonia. And so people have said, all right, could the same thing be applied for blepharospasm? So there are actually a couple of really nice papers out there. When you put all the literature together, there's probably 85 to 100 cases that have been described over the last decade or so. I think some of the really pioneering work's been done at places like UCSF, for example. Here's one of their earlier papers, really demonstrating that using DBS like we do for other indications can have benefit in the setting of blepharospasm. And here's a nice paper that I think that kind of summarized at least a case series of 10 patients. And you'll see, looking at the right, everybody had benefit, both short and long term, but there was varying levels. We obviously had some patients that were very low, maybe 25%, but then others as high as 87 to 93% of benefit. So we talked about here, how does this work? So I think there's still a lot of room to learn about how do we use this better. So still very, very investigational. And I think what we're realizing, especially with the last figure showed, the results are not immediate. And this is consistent with how we treat dystonia. So some of the things that we treat with DBS, the minute we turn on the stimulation, we can see benefit within seconds. Dystonia and other conditions are not like that, where it takes time. And therefore, it can be challenging to know, when are we going to see that benefit? Is it in 1 week? Is it 1 month? Is it 6 months? And so there's still a lot to be learned there. But what I thought would be nice to kind of close out this talk is just kind of introduce the steps involved in DBS to kind of help kind of take away some of the mystery that's involved with this, so people understand, what is this like? So as this hopefully becomes more of a therapy in the future, something that you can consider. So very briefly, this is how we do it for the large majority of indications that we do at Duke. Step one is putting the patient into a head frame, something that's going to allow us to keep the head still for the surgery. It's going to help us really keep the patient comfortable. But this frame is also basically our map. We use this to get all the coordinates that we're going to target within the brain. After that, we make a couple of incisions, make a couple of holes on the top of the skull, just enough, about the size of my thumbnail, just to get access to the brain. So yes, this is an invasive neurosurgical procedure, but compared to other things that we do, like brain tumors, the amount of area that we're exposing, the amount of brain that we're exposing is much, much smaller. And then once we have those small holes, then we can safely pass electrodes down into a wide variety of places in the brain. So like I said, the one for blepharospasm is going to be the globus pallidus, which is going to be this example. I'm not sure if my cursor shows, but the one here, where once again, a central part of the brain, very deep in the brain, but one that we use quite commonly for a variety of indications. After the electrodes are in, for certain conditions, we can actually begin testing in the operating room. So we're actually doing this surgery with patients awake. And what's really nice about that, for depending on the condition, we can get feedback. We can see, is the patient actually seeing symptom benefit? Blepharospasm may not be one of those that we can get that immediate benefit, but for things like tremors, we can actually see that. More importantly, though, what we can also get immediate feedback on is if that electrode's in a position that's going to cause side effects. As you can imagine, we're targeting very small areas of the brain. There's a lot of high-value real estate close by. We're going to make sure that we're not going to cause another problem by trying to treat this condition. And once again, having the patient awake and getting that feedback can be very, very helpful. And after that, we close up, and then the patient comes back and sees, depending on the condition, they'll see psychiatry, see an epileptologist, we'll see a neurologist, to essentially turn on the device and start programming it. So in terms of the actual surgery recovery, so despite all the steps involved, patients actually usually go home the very next day. Of the things that I do as a neurosurgeon, this is probably one of the best tolerated. So it's rare for a patient to have a long, protracted recovery. It does happen, but it's rare, which is really nice. And then usually by about 4 to 6 weeks, patients are kind of back at their baseline, and that's typically when we're turning the device on and beginning to get benefit. So with that, I'll stop and take any questions. Thank you.